right, then we will begin. As you've read in your program, certain aspects of Dr. Schmidsberger's work, I'd been talking to him before this presentation. He is the president of an association of parents, and in hopes of getting me to explain that to you in a way that you will understand, he said the title of the organization, and please bear with me, is Deutsche Herzhilfe, which means help the heart. And that really explains pretty much of what he is going to present to you today. And of course he's going to grade me on my pronunciation too. But let's, he is from Austria, by the way, and he commutes to Germany very quickly, I'm told. He just zooms along in those kilometers and does his work in the car, right, with an excellent driver. Let's give him a nice warm welcome, Dr. Peter Schmidsberger.
Grüß Gott, meine Damen und Herren, as we say in Austria. Before I'm going to tell you briefly what I want to tell you in detail, let me start with some, so to say, philosophical remarks based on astonishing facts. Most of us are inclined to think that medical progress in the large 10 to 12 civilized countries in the world leads to the same schemes of treatment, through medication as well as surgical procedure. Taking some inevitable time leads or respective time lags into consideration, modern science should force the doctors to learnings which should result in an approximation of treatments in all respective countries. I want to quote some exciting figures which will show you that this statement does not come to the truth at all. It is quite astonishing to state that the number of IOL operations, intraocular lenses, in the United States of America per 1,000 inhabitants in 1989 was almost 150% higher than in Germany, Sweden or the Netherlands. There are no epidemiological figures that would indicate a higher frequency of obsolete natural lenses among the population of the countries compared. On the other hand, it's astonishing that the number of appendix operations in Germany is much higher than in the States, 3 times as high. Why should the Germans suffer from more appendicitis than US citizens? In this context, it will be more understandable for you that the number of heart bypass operations in the United States per 1,000 inhabitants is much higher than in Germany or other comparable countries. 150% again. To me, these and other examples indicate that the so-called medical progress is highly determined by economical interest, socio-geographic and cultural differences in different civilized countries, and an astonishing tendency to stick what I call fashions in the medical business. Obviously, it is not easy to overcome those fashions with new objective insights, especially on the field of cardiology. To put it in a nutshell, in spite of all progress, cardiology is in a crisis. My thesis is that pathological blood, especially the high viscosity, is much more a factor of importance for an infarction than the narrowing of the main coronary arteries. The importance of the large blood vessels has been overemphasized compared to the capillary areas, respective the heart muscle itself. In this context, a widely forgotten potent drug should be a first-order medicine for prevention of heart infarctions. Ladies and gentlemen, the 11th World Congress of Cardiology in Manila has supported a demand that the years 1990 to 2000 be declared the decade of the heart, and that the General Assembly of the United Nations should be requested to pass a respective resolution. The reason why is clear. Heart infarction has become the principal cause of death, the killer number one, not only in the United States and Europe, but also in other countries everywhere in the world. This demand, at the same time, is a signal for the cardiologists themselves to take serious thought on the matter. Although the medical profession, respective scientific community, we like to talk of advances, improvement, progress, especially when the number of cases in a disease declines. But vice versa, as soon as more people begin to suffer or to die from a disease, not the doctors, but the patients are held to blame. However, this paradox should not prevent us from speaking of a crisis of cardiology. Though this practice of shrugging off the blame might keep the image of the doctors, it is waste of time towards our goal, which is to improve the health of the heart. The past years saw two publications of two scientific works which should have caused a great stir, but which went largely unnoticed. The findings of both the studies are challenging. First, the author of one of these two works is Dr. Epstein of the National Heart, Lung and Blood Institute in Bethesda, Maryland. His studies at first glance appear to be paradoxical. All his conclusions are the opposite of what you read daily in the papers or what you hear from your doctor, that arteriosclerosis, the narrowing of the coronary arteries of the heart, causes an infarction which destroys part of the heart muscle. Dr. Epstein says, no more and no less, that the more the coronaries narrow down, the less danger there is of heart infarction. Second, the second investigation I wish to report here is by Dr. Ernst, recently appointed to the University of Vienna. He has been working over the years in a rehabilitation center in southern Germany, monitoring patients suffering from heart infarction and stroke. He came to the important conclusion that the thicker and more viscous the blood, the greater was the danger of a repeat infarction. And when the flowing quality of the blood could be improved, the likelihood of a new infarct was greatly lessened. Pathological blood is one of the main factors for the frequency of reinfarction. How are these results to be explained? What do they say? What do they mean? Blood can scarcely flow through blood vessels stiffened and narrowed by arteriosclerosis. And when the narrowing reaches 70%, according to Hagen-Poiseuille's law, only 1% of the original blood amount can flow through the blood vessel. I lay particular stress on this 70% because many surgeons maintain that at the latest, when this stage of narrowing down has been reached, whatever the circumstances, an operation is imperative. It must be done. Dr. Epstein has also confirmed that in an advanced state of the narrowing of the coronary arteries, the supply of blood to the heart muscle is fully assured. To understand this apparent contradiction, one must realize that the heart does not depend solely on those arteries wrestled like a corona around its outside, which are so clearly visible on an X-ray picture. And the thick muscle layer of the left ventricle, where any infarction begins, there is a finely meshed network of blood vessels entwining with each other in innumerable crossings. In their effectiveness for the blood transport, these are comparable to the network of streets in a town. What happens should an accident block one of the main roads? Obviously, traffic would be diverted to the side streets to avoid the blockage and keep it flowing. And what happens in the heart? Could you really imagine that nature is not as clever as our town planners? If one of the main arteries narrows down, the diversion of the blood begins through these intramural subsidiary blood vessels. This network of blood vessels has another advantage over the rigid road system of town, in that possessing a preset growth automation. The tiny vessels can enlarge themselves into remarkable channels to take over the transport of blood. Collaterals, or anastomosis, is the medical term for them. Accurately named, they are precisely natural bypasses and nothing else. Dr. Baroldi has made these collaterals outstandingly and impressively visible. In year-long studies at the Armed Forces Institute of Pathology in Washington, he has developed a technique for filling the arteries of the heart with artificial blood, a chemical substance which later thickens in the blood vessels. When done, the tissues were dissolved in acid. A fascinating sight was revealed. The large, the small, and even the finest blood vessels of the heart lay open to view, a piece of artistic creation. First picture, please. Can you slow down the light? These casts displayed clearly what X-ray photos kept hidden. This made visible a substitute system of blood circulation that helps to understand Dr. Epstein's finding. Second picture. You see all that collaterals and anastomosis between the big branches of the heart arteries. However, this also brought disagreement with those whose first precept is to hold sacrosanct the theory of the coronary cause of heart infarction. It is that the primary cause is the blockage of the large blood vessels. When these pictures are closely examined, it becomes impressively manifest that heart infarction and the condition of the coronary arteries are two different things. Third picture, please. You see here an occlusion of the big branch, and you see that the artery behind is tightly filled. The same here, another heart, occlusion and no infarction behind this occlusion. Dr. Epstein's and Dr. Patholdi's research should really galvanize, should really shake up the practice of heart medicine, and more especially the coronary surgeons. It would make an analysis of the state of cardiology possible. It would make us understand why whether the blood is thick or thin, or has a higher or low viscosity, is of such tremendous importance. Because the smaller the lumen of a blood vessel is, the more important is its fluidity. Collaterals, and above all, the vessels distributing the blood to the cells of the organs, have a markedly smaller circumference. So, for instance, the coronary vessels. The finest of these little vessels can transport blood only when it flows easily and is not thick like, for example, ketchup. Otherwise, there are congestions, and the process of supplying blood to the heart and the removal of metabolic waste products begins to falter. How can one measure the fluidity, the capacity for flowing of the blood? For that, there are several guidelines. The simplest indication can already be gained by determining the hemoglobin and the hematocrit count. Hemoglobin, the red blood pigment, is well known to you. Hematocrit shows the percentage of the solid particles and also the blood corpuscles and the blood volume. A hematocrit count of 45 indicates, for example, that 45% of the blood is solid and 55% fluid. In this connection, may I remind to you of the Puerto Rico health program. In this study, the group with a hematocrit count of over 49% had more infarctions and heart deaths than the group with a count of 42% or less. According to the age, the frequency of infarctions and death was 2 to 4 times as high. In the oldest age group, when the hematocrit count was 50% or more, there was a dramatic rise in the death rate. From the Framingham study, one can read that the number of strokes rose with the increased percent of hemoglobin. In the field of rheology, the study in the flow capacity of the blood, doctors in Germany have gained important knowledge. They have been convinced that infarction prophylaxis can be effective if a hemoglobin count of 13 grams per cent for women and 14 grams per cent for men, and a hematocrit count of 42 volume percent is not exceeded. All these facts and figures make it clear that the crisis of cardiology also stems from the biased, one-sided overemphasis on the importance of the large blood vessels, while not even taking into consideration the work of the small vessels supplying blood to the heart. If this is taken in account, then the capillary areas, the exchange of blood, the heart muscle itself comes more to the foreground. The Deutsche Herzhilfe we have been speaking about, that means Help the Heart, is an association of patients in Germany, and it has for this reason collected over the years scientific papers on alternative cardiological therapies. It had also supported studies and research projects in this field. Rheology was one of the main objects of these activities. Another is the testing of drugs and medicine which have a beneficial influence on the metabolism of the heart. In your program you will find mention of the lecture I'm now making, and I shall be talking about the medicament Strophanthin, especially Strophanthin-g, from Latin Strophanthus gratus. Strophantin has been used with success in Europe as a heart medicine, especially in cases of cardiac necrosis, that means damages of the heart muscle or myocard, for well over 100 years. Since the end of the Second World War, Strophantin has been more and more forgotten and neglected. Cardiologists in the United States must bear some of the responsibility of this. A much to be regretted development in the past few years has now confirmed that it is presumably the most potent drug for the protection of the heart. Strophantin is extracted from the seeds of an African creeper. Its medical effectiveness was discovered by a Scottish botanist who in 1859 accompanied the Livingstone expedition to Africa, where he got a tropical infection with severe heart symptoms and a dramatically accelerated pulse rate. Brushing his teeth the next morning, he was annoyed by a bitter taste. It had been lying next to an arrow poison named combi that he had carelessly packed among his toilet articles. Being a keen observer, Dr. Kirk became, as he told, immediately aware and noted that at one blow, so to speak, his heart pains had vanished. That it was no illusion was confirmed by his remarkably reduced pulse rate. So it was thanks to the illness and to the alertness of a botanist that the heart glycosid Strophantin was discovered. In a number of European countries, and particularly in Germany, Strophantine went a real triumphal tour, a procession of victories. After a few years, it was hailed as the heart medicine. It was praised as milk for the elderly. It was regarded as life-saving when every other remedy had failed. And when in the 30s heart infarction began to increase significantly, Strophantine was more than ever used in cases of angina pectoris and acute heart infarctions. In Düsseldorf, in Germany, Dr. Edens, up to his death in 1944, treated people seriously ill for 15 years with Strophantine given intravenously or also rectally. Quite often, even after only a few days of treatment, heart patients found that their symptoms had disappeared. This positive experience and a high survival rate convinced Dr. Edens that, I quote, Strophantine is the most effective preventive medicine of all treatments for heart infarction. And in his opinion, the time will surely come when the omission of the Strophantine therapy for heart infarction will be judged to be a medical error. End of the quote. When Professor Edens made the above important declaration, Strophantine was already well known in the United States, but it never gained the recognition it had in Europe. On the contrary, Strophantine here was an excommunicated medicine. How could this happen? The term excommunicated medicine occurred in a book published in New York in 1944 entitled Strophantine by Bruno Kisch, medical doctor, formerly professor on the medical faculty of Cologne University and research fellow at Yale University. I quote, "It was the first and presumably the last work published in the English language about such an important drug," wrote Kisch in his autobiography. The rejection of Strophantine, according to Kisch, was based on a misunderstanding with admittedly tragic consequence. Allegedly, through a printer's error in a textbook, lethal doses of Strophantine were recommended, and this resulted in some deaths. Similar doses of other drugs, digitalis for instance, would have, if given, wiped out scores of other patients. However, in the right doses, Strophantine is certainly a blessing for patients with destruction of heart tissue. Kisch had an explanation for this rejection. He wrote, "The great majority of doctors in the United States is still under the influence of psychological shock of the unfavorable experiences of the first years, which stemmed from personal therapeutic failures." He added, "This wonderful method really cannot, in many cases, be replaced by another drug." His vividly worded conclusion was, "The danger of Strophantine is probably far less than that of a knife in the hand of an unwise and unskilled surgeon." End of the quote. So it was that the failure of a few doctors was turned into the failure of a therapy with far-reaching consequences, because in the years after the Second World War, many German students came to the United States to study medicine. When they went back, they took home with them to Europe the negative attitude towards Strophantine they had imbibed during their years of study. The result was that in the years up to 1975, Strophantine in Germany was also excommunicated. Even here, the great tradition seemed to be forgotten after the Second World War. Hardly anyone took the slightest notice of the very impressive description in the textbooks on heart medicine published before 1950, or indeed of the practical experience of the old doctors. They were simply forgotten, or if occasionally they were remembered, they were attacked, denigrated. It was for this reason that the group of doctors and researchers who could put all their energies and efforts into Strophantine therapy remained necessarily small. It is all the more pleasing than that in the face of such circumstances they succeeded in starting a whole series of scientific research projects on the efficacy of Strophantine. This drug has been given a bad name not only because of incorrect intravenous use, but also because due to faulty terminology, it has been put into the wrong category. It has been mistakenly classed with the so-called digitalis glycosides. Also, it is an entirely new and independent heart glycoside. That it is entirely different can already be recognized, for Strophantine is water-soluble, in contrast to the fat-soluble digitalis. Digitalis is retained much longer in the body and so can become toxic. On the other hand, Strophantine molecules quickly send their message to the heart and are soon eliminated. This is why this medicament is free from risks, especially when taken orally. However, this heart pill has to be given in larger doses due to its slow assimilation in the blood via the mucous membrane of the mouth. Its elimination is too rapid and the desired level of effect is not reached. Old textbooks always point out the opposite effect on heart damage caused by oxygen deficiency of Strophantine and digitalis. Experiments have been conducted in which patients suffering from angina pectoris were given respiratory tests. Smaller quantities of oxygen were allowed, and the time it took for heart pains, the commands was registered. Later, these patients were treated either with Strophantine or with digitalis. These tests proved that with digitalis the heart pains began earlier, even earlier than when no medication was given. With Strophantine, the period before the onset of pains was markedly longer. Professor Hans Sarri, who conducted these investigations at Freiburg University in Germany, stated at the finish, "Our practical conclusion from these tests is that with a coronary insufficiency, with or without angina pectoris, Strophantine must be given and digitalis avoided." End of the quotation. This is why the term economization effect on oxygen use by Strophantine has been controversial. Dr. Bereiter Hahn has investigated the subject in a cleverly arranged series of tests at the University of Frankfurt in Germany. He tested the respiration of chick embryo hearts under Strophantine and found a prolonged 30% activation. On the other hand, he found that even when less oxygen was available, the efficiency of the heart cells was not diminished. Here, apparently, Strophantine had led to a better utilization of oxygen and not to a so-called economization. So, Strophantine, even under unfavorable conditions, keeps the muscle of the heart healthy and efficient. An impressive finding, as heart cells are all the most sensitive when the demand of oxygen is greater. In this, the uniqueness of the heart glycoside has been clearly revealed, and it is this quality which sets it completely apart from all other heart medicines. Since in Germany its detractors cannot point to dramatic incidents or to deaths from its use, because when it's correctly used to well-known guidelines, there are no dangerous side effects, they have thought up something else. For the last 8 years, I have had to fight a court case which ended successfully for me in the highest German court of justice, equivalent of your Supreme Court. Speaking, among other things, about the so-called dangerous quality of Strophantine, the experts simply claimed that to prescribe Strophantine for heart infarction is most dangerous because the area of the infarction, as they say, is enlarged. No cases were brought to give weight to this charge. Besides, their contention is invalid as it is contrary to the proven protectiveness of the Strophantine during oxygen deficiency. But, say the experts, it is indeed known that digitalis glycosides improve heart performance, which in turn is thought to lead to a higher use of oxygen, a situation which has an adverse effect on heart infarction. Arguing along these lines, they wrote and cited eagerly and fulsomely passages from medical literature, which, by the way, they have collected in the English-speaking world. But I knew these studies. I myself have collected such records on all literature on Strophantine. But I may be permitted to present you 3 of these works, which have been used in legal proceedings as proof of the dangerous properties of Strophantine. The first is from Dr. Gorlin and Dr. Robin, directors of the clinic in the Harvard Medical School. I know that doctors dislike case studies, but these 2 researchers presented such cases to illustrate the specific use of the cardiac glycosides in the treatment of cardiogenic shock, and in so doing to demonstrate survival from the usual lethal combination of pulmonary edema and shock. Statistics I will present later. First case was a 60-year-old man who collapsed in the morning before admission in the hospital and was found to be cold, sweaty, cyanotic and unresponsive. No blood pressure was obtainable. In spite of emergency treatment, he remained unresponsive and in a clinical shock. He was then given digitalis intravenously. 30 minutes later, the heart sounds became more distinct and he was able to speak and recognize his family. He was given another dose of digitalis and appeared to be doing well. But 1 hour later, he suddenly died. Post-mortem examination showed a fresh myocardial infarction and pulmonary congestion. Comment: death may have been related to a digitalis-induced arrhythmia. Second case was a 49-year-old woman who had developed left chest pain followed by acute dyspnea and cyanosis. She was resistant to the emergency treatment, and as the hours wore on, she remained in coma and pulmonary edema. At this time, Strophantine was given in divided doses. 45 minutes after initiation of this therapy, 3 things occurred. The patient awakened and became alert, the blood pressure was easily maintained, and the pulmonary edema cleared. Comment: shock and coma were successfully treated with Strophantine. Third case was a 65-year-old woman. She developed severe substernal pain with radiation down to the left arm associated with progressively severe dyspnea. She was cyanotic and foaming at the mouth. About half an hour later, she lapsed into coma and appeared to be in a clinical shock. Thereupon, Strophantine was given intravenously. The pulse rate dropped from 150 to 120 in 15 minutes. The pulse became strong and she awakened. Comment: the patient with shock and pulmonary edema responded dramatically to Strophantine. In a comment about these 3 cases, the authors write: Strophantine has not been dangerous and has not been a dangerous agent in our hands. The second investigation was made by Dr. DeMotz et al. From the Veterans Administration Hospital, Portland, Oregon. They assessed the effects of Strophantine on myocardial oxygen supply and demand in 11 patients with severe chronic coronary artery disease. They discussed with amazement that, I quote, no significant change in myocardial oxygen consumption occurred after administration which change, according to the textbooks, must occur in such cases. And another point, no symptomatic or electrocardiographic evidence of myocardial ischemia developed in any of our patients. End of the quote. Finally, Dr. Sharma et al. From the Cardiovascular Unit, University of Leeds, England, made tests on the effects of Strophantine in angina pectoris. 6 male patients were trained to exercise on a bicycle ergometer and to indicate by finger-operated light switch the onset of pain. Strophantine was injected intravenously. In their discussion, the authors point out, these studies clearly show that the onset of anginal pain in each of the patients was accompanied by evidence of depressed ventricular function. When Strophantine was given, pumping function of the heart significantly improved without aggravation of pain. It should be noted that no patient noticed an increase of pain in spite of the increase in left ventricular activity. End of the quote. In addition, there was no further deterioration in the electrocardiogram. Comment? These effects are of considerable physiological interest and therapeutic importance. This was the first step in the presentation of my case, my first line of argument. Now I shall turn to the big therapeutic importance which we have just mentioned. You remember Dr. Edens, professor at the University of Düsseldorf, who has pointed out that Strophantine is the most effective drug for use against heart infarction, and that the omission of its use in future will be regarded as a medical error. He was the first to use it widely for acute heart infarction. After the Second World War, it took a long time before the great effectiveness of this therapy could be tested with large number of patients. It was Dr. Dormann, formerly of the University in Bonn, who in the Waldkrankenhaus in a hospital in Berlin made an outstanding contribution. He combined Strophantine with prednisolone because at that time it was believed the cortisone drug would also stop the deterioration of the cells. When Dr. Dormann took over charge in the Department of Internal Medicine in Berlin-Spandau, the mortality rate from acute heart infarction was at 39%. Thanks to the new therapy, it sank dramatically in a little over a year. Of the 93 patients who were admitted there, 13 died. That is 40%. So this was 40% as compared to the former death rate of 39%. In addition, there was neither shock or circulatory insufficiency. The course of an infarction was markedly less complicated, and that meant mobilization therapy could start much earlier. The duration of a patient's stay in hospital could also be halved to about 3 weeks. Whoever now believes that the world of experts would have felt relieved that a solution had been found for the misery of a new concept of therapy would be greatly mistaken. The German cardiologists rejected it with ice-cold indifference. They did not even trouble to check these findings. Strophantine was and remained, as Kish described so accurately, an excommunicated medicine. But Dr. Dormann could not retreat along the trail he had been the first to blaze. He saw the positive results of his heart treatments and not only felt committed to the welfare of his patients so that they might benefit from this therapy, but going beyond this, he wished to spread the news among his colleagues about his new prospect in heart medicine. In a 3-year study of over 270 infarction patients, he noted that 60.2% had died, while 83.8% had survived. This time, he compared his therapy results not only with results of former statistics at the Berlin clinic with the usual therapy, but also with the survival rates in other studies. One such statistic of 1,462 patients from northern Germany showed a death rate of about 26% and a survival rate of about 74%. World Health Organization investigation and 17 European heart centers with a patient count of 7,738 reported over 16% survivors and a mortality rate of about 40%. Dorman 60.2%. From many comparable cases, Dr. Dorman deduced that his combination therapy is really unequal in its success, that is, so long as the treatment is set in course, in good time and early enough. Its effectiveness diminishes the later the therapy is begun. I shall return in the course of this lecture to the importance of the earliest possible dispensation of Strophantine. Developing his method further, Dr. Dorman dispensed additional medicaments which brought about an improvement in blood fluidity. The most experience he gained with this therapy concept, the more positive were his results. In a 10-year study, he could look back at a pool of 1,056 patients with acute heart infarction whose survival rate had reached the 85% mark. The mortality rate therefore came to 15%. Catalogued according to the age group, it looks like this. Survival rates with patients under 60, 92%. Above that age, still 83%. After first infarctions, 9% survived, and after repeat infarctions, 33%. From this, one can realize how important the prevention of the destruction of the heart muscle is. Since most of the deceased in this statistic had a post-mortem examination, it was clearly evident that even the best of therapies could not have helped them. The pathological anatomical results showed such a devastating destruction of the myocardial tissue that not even a minimal vital function of the heart muscle was guaranteed. It could no longer maintain even the tiniest essential pumping function. Summing up, Dr. Dorman writes, a further lowering of infarction mortality could therefore not be expected. During the postmortem, a further most important fact came to the light. More than 3/4 of hearts taken out for examination were large or oversized, very hypertrophied, as the technical term goes. Since the heart, from the moment of a birth, cannot increase its number of cells, it has to enlarge them as soon as there is a demand for higher performance. It has to be hypertrophied. The larger the cells are, the longer is the distance for the transport of oxygen and for the draining away of acid metabolic waste products. Therefore, large, heavy and overweight hearts are simply predisposed toward heart infarction, which ends in death. Mechanisms which result in critical hypertrophy of the heart are therefore risk factors of the first order, warns Dr. Dorman. I would like to call particular attention to two basic essential findings from Dr. Dorman's treatment results. Like others before, Robin and Gorlin, whom I have quoted, in more than 1,000 cases, he has observed that a cardiogenic shock during his regime of therapy was of no importance. Therefore, these complications are significantly one of the major unsolved problems in heart medicine. The result is that supply of blood to the capillaries, the hair-fine distributary vessels in blood circulation, is drastically lowered. This diminished supply of blood to the organ tissues results in overacidity and finally leads to the breakdown of the cell structure. In the textbooks one can read that only 20% of such patients survive. The other finding: the much feared disturbances of the heart's rhythm appeared far more rarely than under usual therapy, and if they did, hardly needed treatment. If one knows that these dramatically accelerated beats can cause a life-endangering ventricular flutter, or that they can even cause the heart's rhythmic beats to stop, one realizes and can appreciate the importance of these therapy successes. These insufficiencies of the heart and the circulation needing treatment are at the same time a much feared complication accompanying acute heart infarction. They can lead to an insufficient blood supply to the organs and can cause a renal insufficiency with electrolyte disturbance. In Berlin-Spandau, the number of patients affected in such a way remained under 10%. This also is an astonishing yardstick for the evaluation of this therapy. All these therapeutic successes, which could not be achieved with another medicament. But there's a further interesting outcome, which is a side result of these documented reports. Dr. Dorman had his pathologists also investigate how much the coronary vessels of the deceased were still permeable. He posed the question, what percentage of these heart arteries, for example, were blocked by blood clots? The figure ascertained gives much cause for concern. In his 10-year investigation, he found that blockage of an artery had occurred in hardly 20% of cases. And I ask you now, what kind of cause for infarction is this when it can only be authenticated in 1/5 of all the cases and not in the remaining 80%? As a logical consequence, Dr. Dorman relinquished all therapies which would lead to the dissolution of blood clots. He said, and I quote, "Precisely because of the well-known side effects of such therapy, its use in any case with a majority of our patients was not justifiable." End of the quote. And now you will ask me, what did Dr. Dorman's colleagues have to say about these therapy successes? Let me quote the comment of the director of the Cardiology department of another Berlin hospital. Speaking for himself and all other colleagues of Dorman, he pronounced, "Dorman's statistics are too good to be true." So much for the subject of science in cardiology. Dr. Dorman has, in the course of time, suppressed all missionary zeals. And in the conclusion of his 10-year study, he added resignedly, "After this all, further discussion is no longer necessary. The fact is that where there are no contraindications in the treatment of standard cases of acute heart infarction, our scheme of therapy is strongly to be recommended." Then Professor Dorman went into retirement. But I would like to return once again to his statement that the mortality rate cannot be lowered any further. From his clinical point of view, he's surely right. But do remember also the statement I have quoted, that Strophantine should be administered at the earliest possible moment. The therapy for acute heart infarction administered by a doctor has its limits. It is a different matter with self-medication by the infarction patient, and above all, with therapeutic prevention. By this, I mean Strophantine as orally administered, or to the use of the patient's name for it, the Strophantine pill. This form of administration has the advantage that there are absolutely no dangerous side effects. This advantage is that our opinion regarding it has become a real play and interplay of statements causing the utmost confusion because opponents of this therapy simply assert that Strophantine cannot be absorbed, meaning it cannot enter the bloodstream. How are such contradictions possible? After all, modern pharmacology lays claim to using strict scientific methods. The reason lies mainly in the water solubility of Strophantine, which I have mentioned before. Since it is water soluble, it is also eliminated from the bloodstream very quickly, a process which is well known. In addition, the absorption via the mucous membrane of the mouth or via the intestine takes place very slowly. Hence, as compared to an injection, much higher doses have to be administered orally. This high dosage is already being fully used in the campaign to blacken the name of Strophantine. Their argument in this respect is that only about 5% of the medicament could be absorbed. However, such obstacles are easily ignored by those doctors who are, so to speak, discussion happy. The charge made against Strophantine, one reason among others which led to the court case I mentioned earlier, was as follows. Strophantine administered orally, if absorbed, stated the experts, would be a highly dangerous substance. It was now left to the judges to decide whether the drug is now dangerous because it's ineffectual or dangerous because it is harmful. It was an equally difficult and worrisome job to convince the judges of the incompetence of the so-called medical experts and to lead them out of this labyrinth with the help of facts and figures. The research done by Dr. Belz, professor of pharmacology at the University of Mainz in Germany, was most helpful. He had tested the effect of Strophantine on healthy persons. He could clearly confirm a pharmacodynamic effect on the heart, which was different from that made by digitalis. Dangerous side effects were absent. He could refute the reproach of alleged instability, the fluctuation or too scanty absorption into the blood. The deviations were not greater than with other medicaments. The effect on sick patients was tested in a double-blind trial on 30 patients with angina pectoris. After 14 days, it was established that in 81% of the cases, there was a reduction of the attacks, while in the control group of those who had received a placebo, a 72% increase was registered. The pathological change of the electrocardiogram in 31% of the cases had become slightly better, and in 69% markedly so. In the control group, in 86% of the cases, a worsening was noted. This study by Dr. Salz, as well as the one by Dr. Belz, went unnoticed in medical circles. The medical experts at the court of law ignored them completely. In his clinic, Dr. Dorman has also made several tests with orally administered Strophantine. He had treated 150 seriously ill heart patients who altogether had 264 heart attacks. He observed a positive result was registered when the severe heart attacks abated markedly at least 5 minutes after the Strophantine capsule was bitten through, and after 10 minutes at the latest it disappeared completely. It was found that among these patients there was a certain number who had suffered a heart infarction, acute heart infarction, a considerable time past. They were at once treated intravenously. Of those remaining whose treatment was unsuccessful, the figure was 15%. This means that the Strophantine pill therapy had a success rate of 85% in seriously ill patients. Another study on 148 patients is noteworthy because it shows how favorable a regular administration for prevention can be, but only when it is given in time. It concerns a group of patients with unstable angina pectoris who came as outpatients to the clinic. They had all been treated for years on end with nitrate compounds, calcium antagonists, beta blockers, and the full range of other drugs used in modern heart therapy. But there was neither improvement in the general condition, nor did they become symptom-free. After the therapy with oral Strophantine began, I quote, 122 patients were completely free from symptoms within 1 week, and so were 24 more after 2 weeks. Even side effects such as congestion in the head, headache, loss of appetite, giddiness, cardiovascular disorder, and similar symptoms had completely disappeared within a few days. End of the quotation. 2 patients had interrupted the treatment due to intestinal disorders. While this treatment makes clear the possibilities of a prevention therapy with Strophantine, another treatment shows how the cardiac glycoside can be successfully used in an emergency. Especially impressive were the circumstances under which following results were achieved. In a coal mine in West Germany, during a space of 3 years, 10 miners had died of heart infarction down in the mine. There was no one who could help to save their lives hundreds of meters below the Earth's surface. This fact that help could not arrive in time brought about a decision that accompanied doctors to test the Strophantine pill. The doctors, after all, needed at least half an hour to reach the patients down below. Sometimes it took them much longer, and almost always they arrived too late. So they trained so-called safety miners who kept Strophantine pills with them ready for use. The 10-year study shows that since the introduction of the emergency treatment with Strophantine, there was not one fatal heart infarction in the mine. During the 3 years before the study began, every year up to 84 miners stricken by heart infarction and its adverse effects had to be brought up from the mine. 10 years after the records began, there were only 19, a decline of almost 80%. The company physician, Dr. Brembach, compares the use of Strophantine by trained miners to the first aid given at the site of an accident where bleeding injuries have to be dressed at once. Dr. Brembach is in the audience. You can have details from him. Only when these emergency measures have removed in the initial danger does the doctor who arrives later have a chance of helping professionally. The real problem is this. At least 40% of those patients who die of a heart infarction die before the arrival of medical help. They need the help of others, but even better, they should be able to help themselves. The study of cases in the mind is clear evidence that this is possible. Above all, this help is not something artificial or theoretical, it's eminently practical. How much this practical knowledge coincides with the results of scientific methods is shown by an investigation of the Institute for Heart and Circulation Research, Academy of Sciences in Berlin, Buch. Heart infarction patients tested under physical stress, inadequate circulation of the myocard in centigram, that's a radioactive measure. According to a secret code, Strophantine and the placebo were alternatively administered perlingually, that is by absorption via the mucous membranes of the tongue and the mouth. With the patients on Strophantine, after 50 minutes, an excellent blood flow was noticeable in the parts of the heart which had previously shown an inadequate circulation. Above all, in the inner part of the myocardium of the left ventricle, the fluidity of the red blood corpuscle was markedly improved. Ladies and gentlemen, this is the second step of my argument, and I believe it's high time to come to the following conclusion. Every patient at risk, particularly when subjective symptoms appear, should always carry with him an emergency supply of high-dosage Strophantine capsules. In case of a heart attack, only he can help himself. Since he would hardly be in a position to administer the medicine intravenously, he must depend it on oral use. This can only be effective when administered during the initial phase of a myocardial infarction. In this field, experienced doctors demand and strongly insist that the drug should give me within the first 20 minutes and, if possible, even earlier. It can then, it has been proved in practice, be given without risk as necessary and repeated every 10 minutes. The elimination from the blood of this water-soluble active substance takes place so fast that a cumulative effect in the blood cannot occur. When the destructive process in the heart muscle has been brought under control, this therapy can also be beneficial after half an hour or even later. But when it is started too late, the oral Strophantine therapy will not have sufficient effect. With this method of treatment, we have returned to the starting point of our observations. Dr. Kirk discovered the heart remedy Strophantine by oral experience. He tasted it on his toothbrush. Since then, it has been established that oral administration of the drug should be given as much importance as the intravenous. After the Second World War, Dr. Berthold Kern, a general practitioner as well as a heart specialist from Stuttgart, Germany, developed the oral administration further. He was confronted with this necessity because, though on the one hand his patients responded extremely well to Strophantine, on the other hand he could not expect them to come to him daily for injections. In this way, the oral use of Strophantine for the prevention of heart infarction began. But the opponents of this excommunicated medicament could still not be moved from their rigid, hostile position. But certainly, they could no longer say that the oral form of treatment was dangerous. They made a complete turn around and declared that it was ineffectual because of alleged inadequate and uneven absorption. For the facts of medical experience in research in this entirety, for the first time, received appreciation in a court of law. These facts have not been entered in the textbooks. The investigations in cardiology make it clear that Strophantine, even without direct effects on the blood vessels, improves the diffusion of oxygen in the cells of the organs. Strophantine, after all, cannot exercise any influence on pathologically changed arteries. One may therefore be allowed to come to the conclusion that Strophantine improves the metabolism of heart and brain. One is reminded of the wording of the phrase used by Dr. Short of the cardiac department in Aberdeen, Scotland, in the medical periodical The Lancet. There he is talking about the great circulatory paradox when he describes the two opposite phenomena side by side. With the problem of infarction without arterial occlusion stands the well-recognized arterial occlusion without infarction. You have seen it in the picture of Baroldi. Summing up, he states, in any discussion of the etiology of infarction, the metabolic state of the organ is obviously very important. But since we are here concerned primarily with the state of the circulation, a consideration of the factors affecting tissue metabolism falls outside the scope of this review. End of the quote. And with this, we have returned to another starting point. Within the context of my question as the cause of the crisis in cardiology plays a very important role. The papers published by Dr. Epstein and Dr. Baroldi have shown us the great circulatory paradox so irritatingly and at the same time so impressively that we, in the light of knowledge of other therapeutic results, have to ask the question, is it really always legitimate to intervene surgically? Or to put it in another way, Can bypass operations be avoided? Are preventive bypass operations really legitimate? Have we not paid too little attention to the natural bypasses you see here? Today there is no question that the indication for a bypass is very often arrived at too lightly. Dr. Thomas Grabois of the Brigham and Women's Hospital in Boston has, in this respect, presented a study which should give us much food for thought. In the Journal of American Medical Association, he concludes, we examined outcomes among 88 patients referred for a second opinion as to need for coronary artery bypass graft surgery. All patients had undergone coronary artery grafting, which disclosed in 63, this is 72%, cases multivessel coronary artery diseases. Continuation of medical therapy was recommended for 74, this is 84%, and of the 88 patients, of these 88 patients, 60 of these 74 patients chose this option and continued to receive medical therapy without any fatalities during a follow-up period of nearly 38 months. We conclude that second opinions for selected motivated patients slated for coronary artery bypass graft operation offered a significant and safe option. Moreover, a majority of patients will adhere to a second opinion recommending medical therapy, thus reducing the need for surgical intervention by as much as 50%. End of the quote. Grabois has since continued his investigations and expanded them with a larger number of patients. The trend has been confirmed. The strongest argument for bypass is the apparent logic of this operation. Since the obstructed channel for the bloodstream is replaced by a new one, which optically with X-rays can be demonstrated very impressively. Not less convincing is the fact that 70% or even 80% of the operated patients, according to the statistics, feel free of any bodily ailments after the operation and partly stay that way over a long period of time. But the logic wears thin when one takes into account the existence of so-called blood bridges or collateral vessels and the so-called sham operations. In those trials, in the United States, patients were brought for a heart operation into the operation theater and given an anesthetic. After that, the skin over the breastbone was cut. But then, the operation was stopped and the wound was closed. When the patient woke up in his sick room later, he was told that the operation had been successful. And there it was. About 70% of the sham-operated patients were free of symptoms, not much different from the bypass patients. And up to this day, no one has yet found a convincing explanation for this. But we have to ask ourselves whether the big operations are really justified when a little cut can have the same result, and especially since the statistics for coronary artery bypass operations give no cause for confidence. Let us call to mind the following. When the famous coronary artery surgery study, CAS, after a duration of 10 years was concluded, the world of professionals was richer by two findings. On the one hand, the patients after a bypass operation had, on the average, not survived longer than the heart patients treated with medicaments. On the other hand, the theory that preventive therapy could lower the mortality rate of the heart patients was not confirmed. The actual bypass boom, it was again and again explained, was only started by operations on such patients who had shown no heart symptoms at all or only very minor symptoms. So even when healthy persons were operated on in order to assure their maximum blood supply, the success driven for did not materialize. It made no difference. This again indicates that apparently it is not solely the condition of the big arteries which matters. The bypass, it was pointed out in commentaries, is not a causal but a symptomatic therapy. Against this opinion stand the result achieved by those doctors who treated patients due for bypass operations with alternative methods. Unexpected results were attained not only with measures to improve the fluidity of the blood, but also with drugs for the cardiac metabolism. In most cases, they succeeded in avoiding the operation in spite of the fact that they could make no change regarding the narrowed arteries. What is missing today are large-scale multi-center studies where what can be achieved with a combination of these methods of treatment can be examined. Pilot projects have already shown encouraging results. And the program, a reference was made to an investigation by Dr. Dorman in Berlin. In his study, 13 bypass operations that had been planned could be avoided due to the success of therapeutic treatment. Those heart patients were given, apart from oral Strophantine, only one medicament which improved the fluidity of the blood. This therapy can be improved by further measures for the hemodilution. Perhaps my lecture today will contribute to the large-scale establishment of these multi-center studies. I do not wish to assert the thesis that victory over heart infarction can be achieved by this combination therapy alone. But basic scientific studies and clinical experiences have shown that other ways exist than the ones so far taken. I should like to suggest that these other ways should also be investigated. Ladies and gentlemen, let me wrap up what I presented to you. A number of good data support the hypothesis that Strophantine should be used as a weapon of first order to fight heart infarction. It is not only an excellent emergency treatment, but should also be used widely for prevention in a prophylactic scheme. I do not pretend to have the whole truth in my hand. Maybe we find other drugs which even are superior to Strophantine, but we know that we have Strophantine. We know the good data. We can start with comparable multi-center studies. During the last annual meeting of the American College of Cardiology in New Orleans, it was mentioned that every year 1 million US citizens suffer a heart attack. Of these, about 60% get to a hospital alive. Of these, about 16% leave the clinic in a coffin, and a further 10% die within 1 year. Such the statistics form the background for my suggestion. And perhaps I shall also be allowed to point to the economic aspect. Even if the price of Strophantine due to an increased demand should triple, the cost per day should not be above $1.50. Even ill-disposed critics of my thesis could not possibly maintain that the cost for the treatment of patients before and after heart infarction would increase. Ladies and gentlemen, I thank you for your attention.